A 54-year-old man is brought to the emergency department because of change in his mental status after 2 episodes of short tonic-clonic seizures in the last 2 weeks. He presents with confusion and dehydration. He is unable to answer to questions coherently and rambles with an unclear flow of ideas. His son admits that his mental status has deteriorated over the last 2 months, gradually. It was just a slight forgetfulness in the first few weeks, but recently it's progressing to confusion and lethargy. His son also says his father has a history of drinking alcohol for about 20 years, and it's been 4 days since his last drink. His vital signs include a blood pressure of 170 per 90, heart rate of 130 per minute, temperature of 101 degrees of Fahrenheit, and oxygen saturation of 95% on room air. A brain CT scan was performed without contrast that revealed no acute change. There is just a slight brain atrophy that is normal for his age. On the physical examination, his pupils were normal in size and reactive to light and accommodation. Other physical examination was also normal. Now here is the question. What is the most likely diagnosis, and how do you manage this patient? Please think on the questions first and get your own answer ready, then watch the rest of the video. Normally, the first thing comes to mind as the reason of altered mental status, or AMS, in this patient is the sudden withdrawal of alcohol after 20 years of regular alcohol consumption. This is called Delirium Tremens, which is a medical emergency and is life-threatening. It typically emerges 48 to 72 hours after the last drink and peaks at 5 days, with symptoms lasting up to 2 weeks. Without treatment, the mortality rate reaches 50 to 20% due to cardiovascular collapse, seizures, or other less common complications like pneumonia. The first priority is to hospitalize the patient in the ICU unit and stabilize the patient by controlling the seizures and withdrawal symptoms with benzodiazepines as soon as possible. For refractory cases and those with no response to benzodiazepine, we are going to use phenobarbital or antipsychotics like haloperidol. Then the supportive care should be started soon. Thiamine, folic acid, vitamin B12, and other vitamins should be administered, and aggressive hydration should be initiated. Glucose should be avoided until thiamine is given. Although these patients' findings are likely to be due to alcoholism and the complications of alcohol, we need a careful differential diagnosis for neurological problems to assess for conditions like meningitis, drug toxicity, electrolyte abnormalities, and a stroke. Metabolic derangements may include disorders of temperature control, electrolyte balance, glucose or hormone levels, or vitamin insufficiency. Both hyperthermia and hypothermia can cause alteration in mental status. Electrolyte disorders include hypernatremia, hyponatremia, hyper and hypokalemia, hyper and hypoglycemia, and hypercalcemia. One of the most common causes of AMS is infections like pneumonia, urinary tract infection, or COVID-19. And another common cause is head trauma that causes brain hemorrhage. Acute vascular disorders also like malignant hypertension and arrhythmias can lead to change in mental status. In a mnemonic, we can memorize all causes of AMS as I watch death, as you can see here in the table. Rapid identification of the cause of AMS is needed to treat the patient properly. The etiologies of AMS are various and multifactorial in most cases. Patient safety is our goal, and the ABCs of resuscitation and adequate hydration must be done before everything. At the first line investigation, we are gonna be checking the laboratory tests including arterial blood gas, complete metabolic panel, CBC with differential, chest X-ray, electrocardiograph, and liver enzyme level, focus testing for ASA or aspirin, acetaminophen, and tricyclic antidepressant depends upon the history and clinical suspicion. After having all this done, we are gonna check the second line investigation and choose the proper ones for the patient. For example, if we suspect infection, we can order blood culture, lumbar culture, or a sputum culture if needed. And if we suspect any brain trauma or brain mass, we order brain MRI or CT scan. And also, if you suspect any trace of drug poisoning, we can check toxicology test. So in the second line investigation, we just choose what is necessary to perform to diagnose the exact cause of AMS, and we avoid using other diagnostic methods. The treatment of altered mental status focuses on underlying cause while providing symptomatic support and preventing complications. The first step, as it's been said, is to check ABC and ruling out all life-threatening conditions. For example, we must secure airway if the GCS score is below 9 or the oxygen saturation is below 90%. The IV glucose should be administered if the blood glucose level is under 70. Reversing opioid overdose by giving naloxone to prevent respiratory depression. Treat seizure by giving benzodiazepines or its alternatives. And if there is any sign of shock, IV fluid and vasopressor should be given. After ABC approach, now it is time to perform critical intervention based on a cause. For example, if the patient has sepsis, we must start antibiotic therapy and fluid resuscitation as soon as possible. If there is malignant hypertension, we use intravenous antihypertensive medications to reduce the blood pressure. If the patient is hypothermic, we should rewarm him. And if there is heat stroke, we use ice packs or cold IV fluid to rapidly reduce body heat. Altered mental status is always a symptom, not a diagnosis. The outcomes depend on reversing the cause soon enough to prevent upcoming complications. If AMS remains untreated, the mortality rate exceeds 20%, so that is why we consider it as a medical emergency.